Hi. Well, thank you, everybody. Thank you for inviting Steve and I to deliver and talk to you about our work at the QE Hospital. I've just put a few things together on the slide. I'm the head of health improvement at Charlton Athletic Community Trust. You can probably see the brand somewhere down there. Why am I working for a football club? Well, that's because we're a community voluntary sector organisation that works. Good. Community voluntary sector organisation that basically is commissioned by public health. We have a public health workforce here, and we have done since 2006, when the smoking ban first came out, and we trained up football coaches to be stop smoking advisors. And from that time, they've developed through a range of behaviour change support for the public and become a workforce for public health in many different areas, including a 2-year project where we did, I think it was 10,000 blood pressures. They've worked on a health check program. It's all community voluntary sector. Currently, we're commissioned to deliver 2 key aspects of the infrastructure for social prescribing and personalised care roles in Greenwich. And that includes a call centre where we have social prescribers we call Live Well coaches, working, supporting people. And also we have about, I think it's something like 45 staff working in practices in Greenwich as in all through the personalised care roles, including the social prescriber, health and wellbeing coaches and care coordinators. With that infrastructure, which is a gift, obviously, we have been asked by the QE Hospital through the board here to support with social prescribing in the hospital discharge team. So what we've done is we've used all of that infrastructure, all of those years of experience and all of those staff to come along and work with the discharge team, and with the aim of shaving off or making sure that people are discharged from hospital in a timely manner. And obviously the pressure's on at the QE in a very difficult situation. Why did they think we would be able to help in that? Well, because of the very things that everyone's been talking about that we've listened to, which are amazing work that everybody's been recounting. Because a lot of the things that keep people in hospital are the same things that send them in: money, debt, benefit issues, not eating well, employment problems, people that are completely not linked to their community in any way. So they're socially isolated, housing issues, domestic abuse, all of those things are keeping people in hospital longer than they ought to be. The conditions that people are living in are the thing that we try to tackle. Yes, there are avenues and pathways to provide some of this support in hospital for the hospital discharge staff. But what we have been able to do is link community voluntary sector support and our support much quicker than you can do in normal circumstances. So if, for instance, people need furniture moved in a home and it's going to be a 4-week turnaround, our team will get that done within a day or two. So at the moment, in the hospital discharge team, we've developed a fantastic relationship with the staff there, and we have a staff team that works in the hospital discharge team every day. They've received 192 referrals so far, and most of them come from the particular hospital discharge team, but the referrals are also received from teams throughout the hospital, social services, and also other local hospitals where Greenwich residents are in terms of step-down accommodation. We do things like temporary key safes, because that we found that was a big problem. There is a pathway for key safes to be installed, but often it can't be done in the time needed to get someone home in time. So we work with the team in Royal Borough of Greenwich, whose job it is to put key safes in. They provide us with temporary key safes, which if Steve's here can correct me if I'm wrong, we can put in place in 20 minutes. Then we can wait. Sorry, Steve.
Yeah, that's correct. Yeah, they're just basically a large padlock. So as long as there's somewhere to put a padlock at the property, it takes as long as it takes us to get from the office to the property, which on average is about 20 minutes.
So that will shave off even days of someone's getting discharged from hospital. Thanks, Steve. And what will happen then is that the team that are meant to put the key safe in, they can do that in their normal time period. They'll go along, put the permanent key safe in and give us the temporary one back. We do lots of furniture moves in the same vein, where it's going to take a week or two. We will go in and move the furniture so that occupational health can get their kit in there as soon as possible. Do you want to move on to the next slide for me? These are the pathways, really. You can see that most of the people here are, oops, what happened there? Pathway 1. This means that they're discharged with the support of medical equipment or, you know, the package that's required. And you can see that pathway 2 and 3 are 4%, 6%, and pathway 0, 22%. We're commissioned, luckily, very similar to everybody else, to support people with whatever's important to them. So we will get a referral from the hospital discharge team, which will be quite narrow in scope, which is this person needs some food, needs some furniture moved, and they need maybe a befriending referral. But when we speak to the patient, we see them up on the ward. We'll get the referral. Our team will then go up on the ward and speak to the patient, and we will ask them that question: how are you getting on with the cost of living? How's it affecting you? And they will tell us. That will all open doors to different kinds of support, all of that stuff that's going to help support somebody in the community, and the wider determinants. So I remember a referral that I was dealing with where somebody was being discharged home, but actually was in a situation where there was cuckooing, which is where people have moved into the property because this person's vulnerable, acting as though they're family and friends, but in fact they are there taking all the resources, making the place into something that's not habitable anymore, and obviously oppressing and stressing out the patient. So once they tell us things like that, we are able to then marshal a different level of support in the community. With our programme, we have a multidisciplinary team that sits every Tuesday for cases such as that. So the referral will come in from hospital discharge. It will be about removing furniture. Once we look into it, it can't be done. The cuckooing situation needs dealing with, and it's quite complex and quite time consuming. So the multidisciplinary team on Tuesdays has housing, Oxley's mental health team. It has the welfare rights team on it, and also GPs, and we invite whoever's necessary, so it could be environmental health, to come on, dependent on patient need, to work through solutions, and it works really well. We're able to put orders in place, environmental health orders, and get people moved on, and get cases referred to the MASH team, and any place that's necessary to move the situation along in a positive manner. Next slide, please, Steve.
Sure, thanks, Deb. Just to flag, probably only about 2 minutes left.
Okay, no problem. Next slide. So, as I said, referrals come from all sorts of areas: Princess Royal Hospital, Langton Way, which is a care home step down, and our team will invariably support people with what really matters. And having the staff on site at the hospital discharge is really important. There's one more thing I wanted to explain. We have another piece of work in the urgent treatment centre. If you want to click through a couple of slides for me. Yeah, just another one more.
That's it.
That's it. So we've also been piloting a social prescriber, or a team of social prescribers in the urgent treatment centre, and we did this for 8 weeks. In 8 weeks, we had 99 referrals. That's slightly different in that a lot of the work there is in supporting people that are not registered with a GP. So there's predominantly lots of GP registration and appointments, but there's also lots of housing needs, homeless people, getting them back into the housing market. Lots of people, we've got domestic violence, and people need support with that kind of thing, and getting people dressings and things like that. Lots of health and wellbeing support in general. So the projects are kind of both in pilot phase, really, but they've both worked so well at the moment. We haven't got any kind of outcome data other than what I'm showing you here, but I'm sure that if next time we'll be able to explain a little bit more about how both those projects are going. Thank you.
Amazing. Thanks, Deb. yeah, apologies that we had to kind of rush through that a little bit. Sorry for the lack of time, but it was really, really great to hear more about the project and the amazing work that you're doing and the great kind of partnerships and relationships you've built with the local community as well. So thank you so much for that.
Just one thing I'd want to say was in
Yeah.
terms of data, we've got all the staff that work in GP surgeries. That means that patient notes are written back into EMIS in primary care. So that makes it a lot easier to link what's happening in secondary care with that person. Sorry.
Thanks, Deb. No, that's really helpful. That's a really helpful point. Thank you.